Welcome to Channel 17, the Town of Colonie Government Channel.
Hello and welcome to Focus on Health. I'm your host, Peggy Mello. Today's guests are Dr. Arun Puranik, a radiation oncologist from Image Guided Radiation Therapy in Latham, and Glenn Spielman from the Man-to-Man Support Group. Welcome to the show.
Thank you.
Dr. Puranik, do you want to talk about how you've ended up where you are as the Director of Image Guided Radiation Therapy?
Well, Peggy, I started out in radiation oncology back in 1975 as a resident in India, and then I practiced there for a few years before I came here and joined Syracuse, a residency program at Upstate Medical Center. And after finishing my residency and fellowship, I was at faculty at Albany Medical College for 5 years between 1985 and 1990, and then I moved out to community practice. I was at Samaritan Hospital in Troy for 15 years, and then 2 years ago we started this new program with image-guided radiation therapy in Latham here. I happened to initially be interested in radiology and radiodiagnosis, but eventually my clinical interest took me to radiation oncology, where we get to treat all kinds of cancer, get to treat different kinds of sites of the cancers in the body, from brain tumors to head and neck cancer to lung cancer to prostate cancer and you name it, gynecological cancers. So it gives us a variety of diseases to treat different parts of the body, and it's a challenge. Every patient walks in with cancer. It's a challenge to treat and cure the cancer.
And the majority of your patients are prostate cancer?
Currently, most of my patients are prostate cancer, but we do treat a good number of breast cancer, head and neck cancer, pancreatic cancer, colorectal cancer. Image-guided radiation therapy is especially useful in deep-seated tumors, where we can actually see what you're treating every day.
Okay, now today we're talking about prostate cancer. Generally, our viewers should know that prostates are only in men. So it's a man's cancer.
Right.
Do you want to talk about incidence and occurrence rates? Or?
Right. The American Cancer Society estimates that this year about 218,000 people will be diagnosed with prostate cancer in this country. And every year, somewhere about 27 to 28,000 people die from this cancer. So you can see every 20 minutes, a person is dying in this country from prostate cancer. So one may hear that you don't have to do anything about this cancer. It may be benign, it might be slow growing, but people do die from prostate cancer.
And I heard you say earlier that it was 1 in how many
One in six
are affected?
Yeah, 1 in 6 people will
6.
get 1 in 6 men will get prostate cancer.
Okay.
So in this room we have 6 people. One of us will get prostate cancer in their lifetime.
Okay. And who is more at risk for contracting prostate cancer?
There are 3 risk factors for prostate cancer. One is age. As you get older, you're more likely to get prostate cancer. Below the age of 40, you have 1 in 10,000 chance of getting prostate cancer. In the age bracket between 40 to 59, you have 1 in 40 chance of getting prostate cancer. And when you go above 60, it's more common. So overall, it is very common to get prostate cancer, and 1 in 6 men in their lifetime will get prostate cancer.
Okay. And is there any relation between the races? Who is more at risk?
Right. African Americans have higher incidence of prostate cancer. People with genetic history, like if your family, your brother, your father had cancer, is a higher incidence of prostate cancer. And they're also finding that people who eat animal fats, high diet of meat in intake is also associated with prostate cancer.
So is it more meat or more grease? Or
more animal fats, and even if you look at the North America and European countries have more prostate cancer compared to Asian countries, even South America.
So you think that's because in Asia
The lifestyle
they eat
and
more
the
fish
life-
and more vegetables and
Right.
less meat?
Right.
Okay. Now let's talk about warning signs and symptoms. Glenn, do you want to address that? You've had prostate cancer for 8 years?
That's correct.
Is it? Okay. So you want to talk about symptoms or warning signs?
Well, I think it's important to know that there can be no symptoms. What is important is to follow a regimen of good health and healthy checkups. Go for a periodic medical full exam, including a digital rectal exam, and a PSA, which is a blood test for prostate-specific antigen. There can be signs that deal with frequent urination, particularly at night, and other biological symptoms that men can feel from within. However, it's important for people to understand that because it can be asymptomatic, that testing to find if it's prevalent, if it exists in that person, is important.
Okay. Now what about screening?
Well, there are one of the most important methods that since the mid-80s we found out to detect early stage prostate cancer is prostate-specific antigen, PSA.
PSA.
And it's a very simple blood test, and it's very useful. If the PSA is elevated, there's a chance you could have prostate cancer. There's a chance it could be a benign enlargement of prostate. So not all people with high PSA have prostate cancer. However, that gives us a signal, a warning that the PSA is high and further tests should be done. Sometimes you may find prostate cancer without elevation of PSA, especially if it is aggressive cancer. And in those patients, a digital rectal examination followed by a transrectal ultrasound guided biopsy of the prostate is to be performed. And in terms of PSAs, the screening guidelines are men over age 50 should have yearly PSA. People with high risk, such as with family history or African Americans, should start at age 45 or even at age 40. In terms of biopsy, what a urologist would do is put a probe in the rectum and look at prostate, look for suspicious areas, and then perform biopsy of different sections of the prostate. And nowadays, currently, they're at least doing 14 biopsies in different portions of the prostate to get an accurate diagnosis.
So that's part of the diagnostic method.
Right. If people are suspected to have prostate cancer, where there is abnormal examination or high PSA, and those people are subjected to biopsy, and that's the only way to get a firm diagnosis of prostate cancer.
So you basically cover the diagnostics of it. What about treatment? What are the options?
Before we do the treatment, we have to do a staging for the cancer. People with early stage with low risk, low PSA and low grade of prostate cancer may not need further staging. You can just go ahead with either surgery or radiation or whatever method of treatment you want. But people who have intermediate stage disease or high risk disease, one may have to do a bone scan, a CAT scan of the abdominal pelvis, sometimes MRI of the prostate, and then you go on to treatment. There are basically two curative methods of treatment of prostate cancer. One is surgery, where you take the prostate out. It's called radical prostatectomy. And there are different types of radical prostatectomies being performed currently. One is open radical prostatectomy, which is age-old method. We open the abdomen and get into the pelvis and remove the prostate, and then you connect the bladder to the urethra. And the other method is a robotic prostatectomy, where you actually pass some telescopes through the stomach wall and get into the prostate, and requires a smaller incision and less hospitalization. Both methods are currently being used. So that's surgery. In terms of radiation therapy, we have a combination of treatments. One is purely external beam radiation, where we do 5 days a week, Monday through Friday, a total of about 9 weeks of treatment. And over the last 20 years, we have steadily made advancement how we focus the radiation beam into the prostate. Currently, we use what is called IMRT, intensity modulated radiation therapy, where the beams of radiation, small little beamlets of radiation, are deposited into the prostate every day. And through a period of 9 weeks, you perform the radiation. It gives you excellent chance for cure and minimal side effects. There are no hospitalization, and there's no blood loss, and people can play golf or other activities throughout the whole treatment.
And what stages could be addressed with this treatment?
This treatment is done for any stage of prostate cancer except when it is already metastasized to bones. In those patients, there's no point in treating the prostate itself unless it is causing symptoms. So that's the one is the external radiation part. The other part is the radioactive seed implantation. We use either radioactive iodine 125 seeds or palladium 103 seeds, and they go through the needle. We put those seeds into the prostate. It takes about 45 minutes to do the procedure, and it's just as effective as surgery or external radiation. But it requires, spinal anesthesia, needles, and some catheter placement for overnight stay. Sometimes in people with intermediate or more aggressive disease, we may combine seed implants with external radiation. And in that situation, we lower the dose of the seeds as well as the radiation dose. Instead of 9 weeks, we do 5 weeks of radiation. So these are two basic methods of curative treatment. But if some people have cancer which has spread to the bones or metastasized outside, one may use hormonal treatment to shrink the cancer. But at that point, the cancer is not curative.
So what about side effects? Glenn, what can you address regarding side effects?
Well, with each choice, there can be different side effects. Some of them become similar, and whether you do the surgical or the radiation, there is very often urinary incontinence that follows the procedure. There can be rectal bleeding. There can also be temporary or permanent impotence as a result of almost any one of these alternatives. And very often they come together. So those are the primary side effects. Of course, if the disease has already spread outside the capsule, outside the prostate itself, there can be other sufferings such as pain, bone and joint pain, and that, as Dr. Puranik has already indicated, is more palliative care.
Now, if let's say one goes for the radiation therapy for 9 weeks, generally you can go to work full-time and be able to deal with that at the
Well,
same
I can
time?
talk about my experience. Excuse me. After the radical prostatectomy, there was a recurrence, and I had radiation. And the radiation, I didn't miss a day of work.
Okay.
There are others, though, that find that there is an effect on their energy level, a significant effect, so that it, toward the end, since it's cumulative, they're not able to go to work on a daily basis.
Most people would be able to work through the whole. They may feel a little loss of energy and may want to take a nap in the afternoon sometimes. But most people do very well, have no significant side effects. Toward the end of their radiation course, they may get some urinary burning. The rectal complications that Glenn mentioned, that's the big difference with the new technology that we use, is that we image the prostate every day. We do a CAT scan every day before treatment. So we know where the rectum is, if it is too full, or it is, where the location, how much radiation is going to get.
And how often does a cancer move from day to day?
The cancer doesn't move, the prostate moves.
The prostate
Because
moves.
upon how much air or stool in the rectum is. So what we're able to do is actually localize prostate every day, and if supposing a patient has too much air or stool in the rectum that day, we take them off the table and have them take a suppository, clean up, and then we treat. So the new technology allows us to minimize the side effects. In fact, the last 2 years that we have treated patients, we have had almost nobody have any significant rectal complications. As far as the impotency side effects, we're also addressing that. What we're doing now is using a CAT scan MRI combination to fuse the images and exactly find out where the location of the penile bulb is in relation to the prostate. And the penile bulb is responsible for potency preservation after radiation therapy. And if we can spare that, we see a much more chances of preserving potency. As compared to surgery where the nerves are cut and which causes impotency, radiation impotency does not happen because of nerve cutting. It's more effect of vascular effect. It's the effect of radiation to the penile bulb which causes impotency. So we're addressing that issue also, and very, very encouraged with the last 2 years of experience where we have done these kind of technology and in planning and able to spare the keep the potency in a lot of these men here.
Now let's talk about day-to-day living. I'm not sure who wants to address this.
Well, I think we could both talk to it or speak to it.
I mean, number one, we know 2 well-known New York politicians have gone through prostate cancer. Rudy Giuliani and Joe Bruno. Is he still going through it now? I'm not sure.
No, he's finished treatment a long time ago and is doing extremely well.
Okay, so there is day-to-day living is definitely possible.
What happens is when a man is told he has cancer, it's just like anybody else. Men are more impervious than women, I think. But it's a devastating word. And what tends to happen is the fear. The day-to-day living, is like with any significant disease, is a family issue. It has far-reaching effects not only for you but your wife and children. It's the what's next. Then there is a concern about recurrence. So learning about the disease and learning about the alternatives that there are, as Dr. Puranik has indicated, becomes very important. So education is key. Learning about what the disease is, what its effects are, and how they can be addressed, and then making informed decisions which work best for you and your family, and then moving on with, okay, there is life after cancer.
I think one of the problems that we face is that there's not enough information out there. I mean, the information is there, but people are not able to assimilate and make sense out of it. Early stage prostate cancer, when a patient has a low PSA, low grade disease, he has almost 100% chance of living 5 years, okay, even without treatment. So the treatment is done for 15, 20-year outcome. And oftentimes when I see patients and they have had this diagnosis of prostate cancer, they just get very worried. So it takes a lot of time convincing them that treatment will oftentimes cure them and that they would live just as long as they would have lived without having cancer.
Now, I'm the consumer health librarian in the library here, and one thing that I see a lot is patrons that come in that have gone to their doctor's offices and the doctors have explained everything and it's almost like they didn't absorb anything.
Yeah,
so because they're embarrassed over that, they don't want to have to go back and bother a busy doctor. They try to figure it out on their own. So those are a lot of the times what I see in the library.
I would suggest
I'm wondering if I were in that situation, would I bring 3 people with me to the doctors so they could help me remember? What do you do?
we advise people at the man-to-man support group of the American Cancer Society to bring someone with you and to take a notepad to write your questions down and to write the answer down that the doctor gives, even if you don't understand it. Mm-hmm. And then you can take it away with you, look at it again, and reformulate questions. Doctors in this area in particular are very, very willing to take the time and the energy to have you understand. The American Cancer Society's flagship group of the Man-to-Man is an area where men can come with their spouses and talk to others who have gone through similar experiences and learn about what to learn and learn how to learn, so that when they come to you, they have specific questions. We direct them to the internet so that there is access to information that is up to date. Within the man-to-man group, we have a medical advisory committee. Dr. Puranik is one of the noted physicians in the area, Dr. Fisher and Dr. Colonie, so that if there are questions that can't be answered because we in the man-to-man group do not provide medical advice,
Right.
we just provide support and where to go to get it. We can direct questions to the group, to the medical advisory committee on a monthly basis, and they will respond in kind, and at the next meeting we report back to the group the answer to the question.
We also have a cancer coordinator in our office, and patients can always call back her and ask questions, and if she cannot answer it, she'll ask us the question and we can communicate with the patient.
I mean, and basically what you're touching on is how important it is to have that comfortable doctor-patient
Very
relationship. And if you're a patient and you're not getting the information that you need to figure out how to get it.
Yeah.
And whatever information you find, to make sure that it's authoritative and not, going into a search engine and finding somebody's result that may not be accurate information.
Yeah, I mean, I've worked in the entire capital region. I know most oncologists and surgeons in the area, and I can tell you that I've seen most people are very, very good about giving information, spending time with the patients, and explaining, what treatment options are and what to expect. So we're really fortunate in terms of having the oncology community in the area being very supportive of patient care.
So, Glenn, I know I asked you this a few weeks ago, but I'm going to ask you again.
That's fine.
Can you give any advice to anyone regarding how to deal with a person that's been recently diagnosed? I think, I'm not saying that people think that cancer is contagious, but I think that people are scared when they hear that diagnosis. And I'm not saying that they think it's an immediate death sentence, but they're nervous about the worst outcome.
All of those things happen. The immediate cancer diagnosis is felt like it's a death sentence for those who receive it. Then those who are close to those people don't know what to say. But what we are as people, if we're your friend yesterday, we're your friend today. It is not contagious, as you suggest. And the support should be to treat people just as they would normally be treated. We are people living with a disease. And it can be a chronic disease, just like diabetes or any other disease. So don't treat us differently, and treat us with the respect that we're entitled to.
And I remember you saying to me, instead of saying, "How are you feeling today?" that you would say something like, "How are you today?"
Or just how is everything, or how's it going? There's no reason to direct it into health just because someone has been diagnosed with an illness.
I think what helps a lot is to talk to another person who has gone through the treatment or the same diagnosis. And we have people who we suggest that if you would like to talk to somebody, and there are patient volunteers, they can get a phone call and sometimes meet the patients also, just like the man-to-man group, the support group.
Yeah, and what Dr. Puranik is indicating, we have people like myself available to do exactly that. I have gone to the homes because men don't want to come out in public and say, "I have prostate cancer." They think it minimizes their masculinity or whatever.
Right.
So it's easy to talk to someone who has had the disease, who is living with it, and to be able to sit around a table like this with a family and talk. So we have people available through Man-to-Man. I have done that myself many times. We also have a speakers bureau in the Man-to-Man group where we will go out and talk to various organizations or clubs to make people aware that they need to be tested and that even though it's a men's disease, women very often have some impetus on what men do, particularly if we're married, and they should get tested and followed over their lifetime along the guidelines that Dr. Puranik mentioned. So we're there. The man-to-man group is there, and the physicians in the area very often recommend that their patient come to us.
And how difficult is it to get a man into a support group? Do you have any suggestions on how to do that, other than handcuffs and holding them along?
That's how I got in it.
Your daughter got you in, right?
That's correct. That's correct. But in retrospect, when I was first diagnosed, if I had known there was an organization like the man-to-man support group that we have here in the Capital District, I would have been there. I was a medical administrator and didn't realize or what to do or how to do it, and wound up floundering. If I had someone to go and talk to, it would have made a world of difference for me, which is why I'm so enthusiastic and energetic about the man-to-man program and its education in the community.
And how long have you been involved with it? Is it?
About 3 years. We moved to this region about 4 years ago, and I have been active in it since then. I'm now chairman of the steering committee as well as the discussion leader, and am on the board of advisors for the 16 counties the Capital District American Cancer Society serves.
Okay.
I obviously feel it's important.
Now, we have a little bit more time. Dr. Puranik, do you just want to mention real quick what you have in your location, what sort of diagnostic machines, or basically what the setup is?
Right here we have in Latham what is called image-guided radiation therapy. We have a linear accelerator which is equipped with onboard imager, which goes around the patient and takes the image of the area to be treated. So every day we can do a CAT scan of the area to be treated, shift the patient position and bring where it should be and treat. So that we have there. We have consultation services. We also have diagnostic services where we have MRI, CAT scan, bone scan, PET scan, all services are available in the same location.
How much staff do you need at once to do all of this?
Well, every equipment has its own technician and technologists who handle that. So the PET scan is handled by another technician. For radiation therapy, we have 2 technicians, and every machine has its own staffing requirement.
I have to say that when I visited your facility, I was quite amazed at the size of it. It was just, seems to be very large.
Well, we expect that in future we'll be adding more equipment, and we built in a way that if we have to expand in future, we can accommodate more equipments.
And I heard you say earlier that you had patients coming from quite a long distance.
Well, the stuff that we do is high tech. We were the first clinical site in the country to use variants CT guided IMRT. So there was this man who had prostate cancer in Australia, had surgery, and then his cancer was coming back with PSA rising, and he searched around the world and he found us on by our website, and then decided to come here. He also went to Memorial Sloan Kettering for a consultation, but decided to get treatment here. So he rented a space right in the motel nearby and was there for 9 weeks and got his treatment. So we do provide the highest quality of radiation therapy, where people have very few side effects and really get excellent chance for a cure for their cancer.
Okay, and for further information, I think we were just going to talk about websites. Your
Well, it's very
website.
simple. The website is igrt.com,
Okay.
and we have complete information about our location, also information about different disease sites and their treatments.
And that's an interesting website because it also has the actual streaming video about the process
Right.
of what the machines do, which is very good. Is there a website for the man-to-man support group?
The best thing to do is to call the local American Cancer Society.
Okay.
There's an 800 number, but the best number to call for immediate assistance here is 454-4005.
Okay.
And that will put you right into the people who are most familiar with the man-to-man support group.
Mm-hmm.
We meet on the third Wednesday of each month on Osborne Road in Loudonville, wherein it's very informal and privacy and confidentiality is respected.
Okay. And another website that myself as a medical librarian would recommend would be medlineplus.gov as well, which I think is the most comprehensive, authoritative site on the internet. So instead of going into Google and typing a search in, just go into Medline Plus and do that. Thank you very much for coming, you two. Dr. Puranik, we're hoping to have you back for a show on breast cancer in the future. Thanks for coming.
You're welcome.
Thank you for watching. We hope to see you next time on Focus on Health.
Welcome to Channel 17, the Town of Colonie Government Channel.